This conference will now be recorded.
Yeah, good afternoon, everyone. Today's topic is chondroblastoma and chondrosarcoma. So, coming to the topic, these may be given as 4 marks for you in the exam. So, the words chondro means cartilage. So, blastoma is a benign tumor and sarcoma is a malignant tumor. So, first we will discuss about chondroblastoma. Chondroblastoma, synonyms are Codman's tumor and cartilage containing giant cell tumor, calcified giant cell tumor, or epiphyseal chondromatosis giant cell tumor. So the question Codman tumor may also be given. So you need to remember it's chondroblastoma. So these are epiphyseal tumors and these are benign. So it is one of the rare tumors. The most common site of chondroblastoma is epiphysis. It was described by Codman, so it's called as Codman's tumor. It comprises of less than 1% of all bone tumors. It develops from cartilage germ cells. So cartilage is called chondro. So we describe it as chondroblastoma. So according to Walls, the histopathologically reticulohistiocytes are seen in the peripheral spleen. Sorry, in the histopathological examination. So age, usually it is seen more during the active epiphyseal plate growth, and it is seen in teenagers before the obliteration of growth plates. So 90% of the patients are from the ages 5 to 25 years of age, and it is more respondent in males when compared to females with a ratio of 2:1. So site already discussed, it's epiphyseal region of long bones and occasionally to adjacent metaphysis. So epiphysis continues as a metaphysis. So it may spread from epiphysis to metaphysis also. And commonly it occurs in lower extremity, 72% of the cases. And any bone tumor, when it occurs in lower extremities, it is usually seen in and around knees. So 50% of chondroblastomas, they occur around the knee. And the next common part is proximal humerus, which comprises of 18%. So the tumors grow up to a size of 1 to 6 centimeters. And the clinical features, usually the clinical features are non-specific and vague. There will be pain and swelling of several months duration, and it may be referred to the nearest joint. Suppose it's proximal humerus, it may be referred to shoulder. If it is proximal tibia or distal femur, it will be referred to the knee joint or sometimes hip joint. There might be some restriction of joint motion and wasting of muscles also. So if it is present around the knee, there will be some joint effusion around the knee. So pathological fractures, that means fractures which occur due to the destruction of bone due to the tumor. These are pathological fractures. This is rare in chondroblastoma. Mortality and morbidity. Without surgical excision, the tumor may extend into the adjacent soft tissues or synovium, and it may metastasize to distant organs. Usually chondroblastoma is benign, but there may be a rare metastasis which may occur to the lungs. And widespread metastasis and death have also been reported with chondroblastoma. So X-rays, this you need to remember. As you can see, there is a lytic area in the proximal tibia. This is a characteristic of chondroblastoma because it is involving the epiphysis and extending into the metaphysis. So it is usually oval or round, and it is comprising less than half of the epiphyseal area. There will be a thin rim of sclerosis. This is the thickened part. Sclerosis is thickened part. This is the thin rim of sclerosis, and sometimes there may be punctate calcifications. And usually it is seen in open growth plates, that is skeletally immature. Here you can see the physis is still open, it's not closed, it's not fused. So metaphyseal extension crossing the growth plate results in eccentric location and bulging the expand. If it extends to the metaphysis, it will be like, it's not seen here, but it will be eccentric and it will cause a bulging of the cortex. So CT scan is a better investigation than the X-ray. where you can see the clear exact evaluation and extent of the tumor. Here you can see it. Okay, this is the proximal humerus. This is the glenoid. This is the head of the humerus where you can see a lesion in it. So this part is the lesion which you can see in the axial cuts. So MRI scan, it is the best choice of investigation, and we can delineate the tumor along with the extension into the soft tissues. So in the X-ray it is seen this way. It's not clear in this picture, but as you can see in the MRI pictures, it's looking very clear, and even in this picture also you can see. So in a 16-year-old girl, this is a pathological fracture which is rare. This is a chondroblastoma of the patella. Okay, this is the patella which is destroyed, and when we see an axial cut, we can see it's almost fractured with expansion. This is rare usually, and here usually you can see a well circumscribed lesion with thin sclerotic margins. Okay, so sclerotic margin may not be always seen in chondroblastoma. Sometimes it may be sclerotic, non-sclerotic, or incompletely sclerotic borders. So MRI, we take a T1 image and a T2 image. Just remember, you need not know what is T1 and T2 as of now. So in T1, usually if there is some edema, it occurs white in T2. Okay, water is white in T2. So in T1, the edema is not seen. But when you get to T2, so this part is the surrounding edema, which is almost a fluid. This appears white in the T2 image. Okay. And here you can see in the case of spine, chondroblastoma may also occur in the spine. You can see the bulge of pedicle and transverse process of vertebra. Okay, this is the bulge we can see. So it is confirmed anytime the chondroblastoma is confirmed only by histopathological examination, not through MRIs or CT. Okay, this is just to delineate the tumor. So here it's a 17-year-old boy with a tumor in the proximal humerus. There is a solid adjacent. Here you can see the tumor is extending into the metaphysis also. Okay, so here there is a periosteal reaction. The periosteum is a little thickened because of the tumor. This might be seen in 15 to 30% of the chondroblastomas. And fluid levels, just remember, it is usually not seen in chondroblastomas. This is seen in aneurysmal bone cyst. But in this picture, you can see this is the tumor. You can see a horizontal line. This part is the fluid. It's like almost some fluid is there below, and you can see it's a water level like thing. So this is called a fluid level. This can be seen in chondroblastomas occasionally, but usually this feature is common in aneurysmal bone cysts. So uptake of bone seeking agent. This is a bone scan. Okay, a bone scan. When you take a bone scan, there will be regional uptake of the tumor. So the proximal humerus on the right side is involved. So there is an increased uptake, which is seen as a bright spot here. Okay. So when discussed about the investigations, you need to write X-rays, CT scans, MRI, and then bone scan. So pathology. Grossly it is seen as a with a capsule, and the tissue is soft reddish purple and friable fritty tissue. There might be cystic spaces and hemorrhages seen. So microscopically, you can see islands of chondroblasts. The small things are the chondroblasts. This can be present in the form of some island with background of stroma. Okay, it looks like a paving stone appearance. Paving stone means we can see some stones in a lawn. That way, the chondroblast can be seen in the stroma. So this can be described as a paving stone appearance. It can be given as a PG bit for you. So just remember the paving stone appearance is seen in chondroblastoma. So, and the cells which are round, plump, and active. And remember this thing also: chicken wire or picket fence calcification. Okay, the calcification may be seen in chondroblastomas, which can be in the way of a chicken wire calcification or picket fence. Picket fence means the fence we usually see. And these are the microcalcifications and the multinuclear giant cells which are scattered in the trauma. Sometimes there might be dilated blood vessels in the center or the periphery. So you need to remember two things, which is paving stone appearance of the stroma and chicken wire or picket fence calcification. So coming to the differential diagnosis, it may be confused with enchondroma, which is more common in hand, and GCT. GCT usually it is eccentrical, and what we see is a soap bubble pattern. Okay, there will be no calcifications in GCT, but in chondroblastoma we can see that calcifications. And chondrosarcoma usually it is slow growth, but margins will not be demarcated because chondrosarcoma is a cartilaginous malignant tumor. And chondromyxoid fibroma, it is usually seen in the metadiaphysis region. But chondroblastoma, we see it in the epiphysis, which may spread to metaphysis. And the monostotic fibrous dysplasia, which has a ground glass appearance. So treatment of this tumor, most cases they do it with curettage and autologous bone grafting. Autologous bone grafting is we can take some bone graft either from the iliac crest of the same patient, or you can harvest bone graft from head of the femurs, which are stored in a refrigerator, which we call as a bone bank. So after the skeletal maturity, we need to follow up the patient because sometimes it may be confused with chondrosarcoma, so it may spread rapidly. So we need to have a close follow-up. And methacrylate etching, methacrylate is PMMA, what we call is polymethyl methacrylate, which is also called as a bone cement. After you curate, the space is filled with either bone graft or a bone cement. And curettage followed by cryosurgery. Sometimes if it is if the tumor recurs or if it is associated with ABC, aneurysmal bone cyst, you need to do a cryosurgery. Like you will have a probe which will give liquid nitrogen. With that, you can destroy the tumor cells and the surrounding tissue. That is called cryosurgery. So radiosensitivity, like radiotherapy, it's a radiosensitive tumor, but in uncomplicated cases, we don't think of any radiotherapy. Radiotherapy is mainly for malignant transformation cases only. So coming to the chondrosarcoma, chondro it's cartilage and sarcoma it's a malignant tumor. So it's a malignant tumor mostly of cartilaginous origin, and most common malignant bone tumor is primary tumor is osteosarcoma. After that, it is the chondrosarcoma. But the most common tumor in a bone is osteoid osteoma. Okay, so primary chondrosarcoma, it is usually seen in the ages of 40 and 60, but secondaries they occur in younger people, which is 25 to 45. So classification primary and secondary. So chondrosarcomas may also be classified as central, intracorticular, clear cell, mesenchymal, dedifferentiated. Just you need to remember these things. Central, which occurs in the middle of the bone, and intracorticular. So if we take a bone, the center part is called medulla, and the part which surrounds the medulla is the cortex. So it may be medullary or intracortical, or these are the variants: clear cell, mesenchymal. And sometimes it may be dedifferentiated, which has a poor prognosis. So chondrosarcomas, it may occur in pre-existing lesions. This is the secondary chondrosarcoma, which may occur in enchondromas, exostosis, or chondroblastoma, or it may be irradiation induced. Like if a patient is given radiotherapy for another tumor, it may cause chondrosarcoma for them. And fibrous dysplasia. So according to the location, it is divided into central and peripheral. Peripheral, we usually call it the surface type. So most common sites, what is the most common site of chondrosarcoma? When asked, it's the pelvis, not the near the knee. The pelvis is the most common site of chondrosarcoma. It's an important bit for you. So just remember, pelvis is the most common site of chondrosarcoma. and after that proximal femur, proximal humerus, ribs, and rarely in hand. And the incidence is more higher in males. Already discussed, the chondroblastoma is also more preponderant in males. So clinical features, there will be a palpable mass with an increasing pain. It is hard in consistency and it grows slowly, but it is continuous with the bone. So as you can see, this patient is having a large lump over his shoulder. Whenever you see this much size of a tumor, you need to diagnose it as a malignant tumor, because benign tumors usually don't grow this big in a short period. So whenever there is a tumor in the extremities which is slow growing but it is continuated and hard in consistency, you need to think of either osteosarcoma or chondrosarcoma. So usually it arises at the site of a pre-existing benign cartilage lesion. Secondaries, they are secondary to some existing bone pathology, which might be either osteochondroma or exostosis or even fibrous dysplasia. So it is most frequently seen in enchondromas and multiple hereditary exostosis. Exostosis, bony outgrowths from the outgrowths from the bone. So incidence, 5% of patients with multiple hereditary exostosis, and in case of solitary exostosis, osteochondroma, it is also called as an exostosis. So if it is solitary, just 1% of patients may have chondrosarcoma, but in multiple exostosis, 5% of patients may suffer with chondrosarcoma. So coming to the radiographs, usually it arises in the medullary cavity. Okay, in the medullary cavity with irregular calcification, and remember this term, punctate or popcorn calcification or comma-shaped calcification. This is the characteristic feature of chondrosarcoma. So as already discussed, in chondroblastoma, it is chicken wire or picket fence calcification. Here it is popcorn or comma-shaped or punctate calcifications. So here you can see, this is described as a popcorn calcification. It's almost looking like a popcorn. It is arising continuously from the bone and extending this way posteriorly. So the complete thing is the tumor. In the radiograph itself, you can describe it as a chondrosarcoma, because popcorn calcifications are seen even on the X-ray. And here you can see the radiograph of a pelvis, where this is ileum. Okay, ileum is completely destroyed and it's having calcifications inside. So as pelvis is the most common site, you can confirm it as chondrosarcoma, but the main investigation we need to do to confirm is MRI followed by biopsy. So in osteochondroma, which is an exostosis, we have a cartilaginous cap. I think it was already described by HOD sir. This cartilaginous cap, we need to describe the size. If it is greater than 2.5 centimeters, it has a chance of getting converted to secondary chondrosarcoma. So histology, in conventional it's normal chondrosarcoma, there will be an abundant cartilaginous matrix in which there will be some malignant chondrocytes. Okay, so if there is any osteoid, we call it as chondroblastic osteosarcoma. And the features by which we can diagnose the malignant transformation in a chondrosarcoma or hypercellularity, plump nuclei, and more than occasional binucleate cells. That means one cell will be having more than two or more than two nuclei, and there will be an entrapment of the bony trabeculae. Because the tumor is a cartilaginous matrix, there will be entrapment of the bony trabeculae. So histological subtypes already described: clear cell, mesenchymal, and dedifferentiated chondrosarcoma. You need not go into the details of this, but just I will describe you. Clear cell is a low grade malignancy. There will be a distinct cytoplasmic stroma with a cartilaginous multinucleated giant cells. The blue things which we see here are the multinucleated giant cells. Okay, so clear cell, it's a low malignant, so there will be a good prognosis. And the clear cell chondrosarcoma, it has a strong tendency to arise in the epiphysis. benign radiological features can be confused with chondroblastoma. So chondroblastoma may be confused with which variant of chondrosarcoma. You need to say it is clear cell. Then it's mesenchymal. This is a high-grade tumor. Small round blue cells, which are the islands of the benign appearing cartilage. We have the staghorn-like vessels with a hemangiopericytomatous pattern. This is mesenchymal, means there will be blood vessels and anything which arises from the mesenchyma. So this is a high-grade tumor, and you need to remember that staghorn-like vessels will be seen in this. Okay. So and dedifferentiated. This is a high-grade uh, sarcoma. It is osteosarcoma followed by chondrosarcoma, which is dedifferentiated. So it may be anything. And the radiography measure an aggressive radiolucent area. So in the chondrosarcoma, what's the treatment? If it is a low-grade chondrosarcoma, you can go for an extended curettage with use of intraoperative adjuvant treatments. What are the adjuvant treatments? Radiotherapy and chemotherapy. You need to curate the tumor, and then you need to do radiotherapy or chemotherapy in order to save the limb and even the patient. Because if you leave some part of the tumor, it may metastasize and may lead to finally may lead to death of the patient. So if it is a high-grade chondrosarcoma, you need to do a radical dissection. That means you need to even go for an amputation if it is occupying the whole of the joint or a part of the extremity. So in low grade, if we do a extended curettage, there will be some recurrence, which will be very high in the case of intraoperative contamination. Like when we are trying to remove the tumor, some part of the tumor, if it is spread into the soft tissues, or intraoperative contamination means when we are trying to remove the tissue, if some part of the tissues may be left inside. So this causes local recurrence rate, which is very high in the case of chondrosarcoma. So if it is a lesion which can be expendable, like if it is in the distal part of tibia, you can straight away go for an amputation rather than trying to survive the limb. So this is mainly to decrease the chance of tumor contamination. And after resection, the local complete resection, local recurrence is very rare, which is less than 10%. But the pulmonary metastases, which are the most common with chondrosarcoma, they need to be treated with surgical resection if possible. If not possible, we need to go for a palliative method, which is either chemotherapy or radiotherapy. So chemotherapy, usually it is not seen in the conventional chondrosarcomas. They have no role. But in the other types, secondary chondrosarcoma, it can be given as an adjuvant. Radiotherapy, it is a palliative measure for surgically inaccessible lesions. Like if you have the chondrosarcoma filium, you cannot surgically treat it completely. So in that cases, radiotherapy may be a palliative measure. So these are the inaccessible areas which are arising from the floor of pelvis or even the vertebra spinous process. You cannot go on removing the completely the pelvis, because you need to have an implant to fill up the space, which is not possible. So in these cases, you need to go for radiotherapy. So the prognosis of chondrosarcoma mainly depends on the size of the tumor. The lesser the size, the better the prognosis. The grade, if it is low grade, it will be better. If it is a high grade tumor like mesenchymal or dedifferentiated, it has a bad prognosis. And the location of the lesion, if it is seen in an extremity, it can be easily treatable. Like you can go for an amputation, at least you can save the life of the patient. But if it is located in pelvis or something, we need to go for radiotherapy, as we cannot go for a surgery completely accessing the pelvis. So these have a bad prognosis, which may lead to metastasis to the lung. So low-grade lesions, there will be greater than 90% of 10-year survival rate. But in case of high-grade conventional chondrosarcomas, there will be only 20 to 40% of 10-year survival rate. Means 60 to 80% of the cases, they result in mortality. Okay, thank you. So any more doubts?
No, sir.
Okay. Okay, thank you. Exit is